It's a great pleasure introducing Dr. Om Ganda. You know, the we always were told by my guru, Dr. Raheja, that this is one point contact in Harvard Medical School. This is a one point contact if you want to go and learn in Jocelyn Clinic. And Dr. Om Ganda was ever willing to give us some berth in Jocelyn, Boston, and Harvard Medical School. This man has got some record number of papers. He is involved in multiple landmark trials, particularly DCCT, IDEC, and multiple NIH trials. He's got more than 150 great publications in many journals. You'll see Om Ganda's name multiple places. He has written more than 35 chapters and books on diabetes, and I have a great pleasure introducing him. And I'm sure I'm equally eager to hear him today amongst all of you. Over to you, Dr. Om Ganda.
Thank you very much, Dr. Baraskar. Can you hear me okay?
Yeah.
Okay, I'm trying to share my screen. And here we go. And let me put on my slideshow. Thank you for that very kind and very generous introduction, Dr. Baraskar. You yourself are an accomplished diabetologist in India. And it's always a pleasure to meet you personally. Hopefully next time we can do that once this tragic period subsides. So I think you can all see my slides. I'm going to talk about, just very briefly, about the HMG CoA inhibitors known as statins, and then go on to talk about PCSK inhibition, how far we have come, and where do we go next. So in this limited time, let me start off with my objectives first. And these are my disclosures. I don't think anything I'm talking today has to do with any of my disclosures listed here. So briefly speaking, let me actually, I think I may have gotten the wrong slide set here. So hold on 1 second. Give me 1 second here. I think I was just finalizing it last night, so I do want to show you my final slide set, which will take me 1 second to open. Forgive me for that. Now I go back to it. So, oops, this was the previous one. Okay, let me screen share again. Resume share. I apologize for this delay. It only take a second. I think I'm trying to find the final slide set. It's asking me to register, which is not what I want to do. Resume share.
You'll have to stop screen share and then probably re-screen share.
Okay, let me stop it and then go back, share screen. 1 second. Okay, let me close the previous set first. And this is the final set. Okay, I'm screen sharing now, Sanjay, but I'm trying to find my slides here.
No worries. Take your time. It's perfectly all right. This is the
Now,
brochure.
just give me 1 second. I think I keep getting this screen.
No, that's the brochure. So you'll have to close that probably.
Uh,
Yes, we have.
Okay, there we go.
Sir, if I can suggest, you are such a great orator, you don't need any screen.
No, I do want to show some very interesting slide that I created just for this meeting, and I try to be as up to date as possible. So let me see if I can somehow get back on the screen share. Give me just 1 second. The screen share, let me stop share again. And let
Open
me,
your presentation first, Om.
Yes, sir.
New screen share.
So please open
First-
your presentation first and then
First open
screen
everything.
share.
yeah. Okay.
Just open a presentation and then you can screen share it.
Yeah, there you go.
No, you're opening the scientific program.
Oh, yeah, sorry.
You have to remove that scientific. I think your
Okay.
presentation below that. Yes.
Yeah, right there.
Right.
Yeah, I thought I just opened it, but somehow I didn't.
Yeah.
Open.
I think, yeah, now
yeah.
you got the presentation.
I'll try to finish my talk 2 minutes.
No
Yeah.
worries. You're the last
We have
speaker.
time, sir. We
You
have.
have the
I
time.
don't want
No
to
worries.
eat up on the. I don't want to eat up on the time for the panel. Can you see it now?
Yes,
Yeah.
we can.
Yes.
Sure.
Wonderful. So again, my apologies, and again, once again, thank you, Dr. Baraskar, for your wonderful remarks. These are my disclosures. So learning objectives. Let's start with the roadmap here. Okay, so I'll give you a brief recap of the HMG CoA reductase inhibitors, otherwise known as statins, and the LDL receptor. We'll then talk a little bit about the historical rationale for the PCSK9 inhibition. Why is it important? Impact of PCSK9 inhibitors on the revised targets for LDL cholesterol. This has played a big role in our new revised, more intensive targets in appropriate patients, of course. And finally, we'll end up on emerging lipid treatment options beyond PCSK9, finally to actually come close to conquering atherosclerotic cardiovascular disease. So that's the agenda. And I know you had a talk on the guidelines for lipids, so I think I'll probably not be going much into that at all, so there won't be much overlap. I wish I could hear that talk earlier. But anyway, everyone knows that HMG CoA reductase is a rate-limiting step in cholesterol synthesis. There are 27 different steps before you finally get cholesterol in place. And let me just hide this button here, escape. So that's how cholesterol is formed. It's a very intricate process, very complicated process, but this is the rate-limiting step. And once the cholesterol is made, it is carried in the body. What happened here? I don't know what happened there. So it's carried in the body in this very beautiful molecule that is called LDL particle. Actually, it's a particle, not a molecule, but many cholesterol molecules are carried as esterified or free cholesterol, et cetera, you know all that we have LDL as the main carrier of cholesterol. And the statins obviously have indubitable evidence for the long-term efficacy and safety in reducing cardiovascular events. So there's no point for me to go into any of those trials, which are well known to you by now. So first of all, the question comes up, what is the optimal LDL cholesterol goal in patients with very high risk of cardiovascular events? And you heard about it in the guidelines, I'm sure, who's at very high risk. For example, people with the recent heart attack and multiple risk factors, people with recurrent heart attacks or strokes or peripheral arterial disease. So this is my summary of all these various guidelines for optimal LDL cholesterol. And right away, I just want to point out the fact that Endocrine Society just last year came up with their latest guideline in distinguishing from AHA, ACC, ADA guidelines, which say LDL should be less than 70. But these guidelines are already 3 years old from the AHA, and they didn't have all the studies that we have now. And NLA said the same thing. Canadian guidelines said the same thing, although they just revised it in 2021. So Endocrine Society says less than 55 should be the goal in people who are very high risk. And even before that, the European Society last year or 2 years ago said, if you have a second event in less than 2 years, you should be shooting for less than 40, because we now have evidence that lower is better. And in fact, less than 40 is better than less than 55 or less than 50. So this is how far we have come. And of course, in India, you have so much cardiovascular disease and so many people that are untreated. So we have to start somewhere, get to 70 before you think about going to 40 or 50. Non-HDL correspondingly less than 70. And if you do ApoB, not necessary, but we do it at Jocelyn in people with high triglycerides. If you can get a reliable method, ApoB is even more accurate than non-HDL cholesterol. Okay, so what do you do next? If you have somebody on as intensive therapy as you can, but it's still inadequate, you have less than 50% reduction, or LDL remains above 70, then what do you do? The minimal goal is 70. Or you have somebody with statin intolerance, not complete intolerance, but they can only take low dose, and that's not enough. So what do you do next? Well, we have a lot of options. This is from a review I published a couple of years ago, where I just listed all of them basically and brought it up to date. And what I want to point out is there are only two classes of drugs that are approved for reducing cholesterol and reducing cardiovascular events after statin. So use statin as much as you can in any dose you can, and then go to ezetimibe first. And if that's not enough, then the only other option is PCSK9 inhibitors that I'm going to talk about. There are two of them on the market since 2015, avelumab and alirocumab. By now, you all know about it, at least may not have used it very much because of the cost issues we'll discuss, but these are the best drugs to lower LDL cholesterol. I'll then go on to talk about a few other options. Now, one word on the ezetimibe trials. The only trial that showed that ezetimibe lowers cardiovascular events beyond statins is this huge trial called the IMPROVE IT study, 18,000 people who presented with ACS, acute coronary syndrome. And they had LDL cholesterol at baseline. Actually, the goal was less than 70, but they were already below 70, as you will see in a second. They were randomized to simvastatin 40 or ezetimibe added to simvastatin, followed for a long time, almost 5 years. And the primary endpoint was the traditional endpoint. So look at this here. The baseline LDL cholesterol was already 70, 69.9. And then they brought it down to 54 or 53, about 20% reduction, as you might expect with ezetimibe. And that led to a significant, not huge, but 6%, but highly significant reduction in cardiovascular events. In fact, people with diabetes did better. In fact, most of the benefit in this trial was in people with diabetes. And if you take out the non-diabetics, just look at the 6,000 or 7,000 people who had diabetes, they had most of the impact with ezetimibe. We still don't know the exact mechanism, but that's what happened. So that's the first line of drug after statin. Then the PCSK9 inhibitor. Very quick summary. What is the mechanism of action and how did they come about and when to use them? Well, it's a very interesting story. You all know that, start from the bottom. This is a liver cell shown here. If you use statins, you decrease the free cholesterol in the liver cell, or that can be done with very low saturated fat diet. As soon as the cholesterol pool in the liver goes down, the liver cell makes this very beautiful receptor called the LDL receptor. And that kind of brings the blood cholesterol from blood to the liver cell or other cells in the body, and that's how the LDL receptor works. But for some reason, the Mother Nature decided we still don't know why, what's the teleological significance, that part of this LDL receptor is actually destroyed by this enzyme called PCSK9. It's a protease enzyme that causes proteolysis of the LDL receptor. So you don't get as much out of the LDL receptor as you should or as you could. So that was the rationale of thinking about how we can block the PCSK9 so that there's more LDL receptor available. Okay, not in people with homozygous hypercholesterolemia who have no receptor, but even heterozygous hypercholesterolemic people have one receptor. And that's where the story began. And this was really a serendipitous discovery. Only about 25 years ago or so, first described by a French study, and then came this beautiful epidemiological study published in New England Journal 2006 by Dr. CoA et al. From Dallas. And they were looking at basically variations in these PCSK9, natural sequence variations. And they ended up with two sequence variations that were accompanied with low LDL, very low LDL, much lower than the general population. And they showed that these people were protected against coronary artery disease because they naturally had no PCSK9 to speak of, and therefore the LDL cholesterol was low in these people. So that started the story. Let me show you one slide from that particular study. So here they looked at presence or absence of these two nonsense mutations shown here. 3,200 African-American subjects were included in this so-called IDEC study. 85 had this mutation, not very common, but some people did have this mutation. And their LDL cholesterol was 100 versus those without mutation who had LDL cholesterol of 138. You might say, well, 100 is not that low, but remember, this was their LDL from birth, not from age 40 or 50 when you start using statin. So that was the difference. And so people with no mutation among these 3,200 people, you can see there was a normal distribution of cholesterol, okay? This is the cholesterol curve. And people who had the mutation, you can see the whole curve is shifted to the left. And so therefore, they had much lower cholesterol compared to these people who had no mutation. And not only that, but since they were following these people for a long time, they found there was a 90% reduction in coronary artery disease events. Huge reduction. Not normally feasible in our hands, because we start lowering cholesterol at age 40 or 50, as I said, but these are the cholesterol levels since birth. So anyway, this was the impetus to develop some methodology to block the PCSK9 and to see what happens to people who don't have these mutations, but we can block this PCSK9. So there are two strategies to do that. One is you can make a monoclonal antibody to this PCSK9 enzyme. And this is exactly what has been done in the two drugs that we have right now on the market. So once you block the PCSK9 by this antibody, you no longer have inhibition of the LDL receptor. So you have much more LDL receptor available. The another smart strategy that is now going to become available in the near future, already becoming available in some countries, is you basically stop the PCSK9 synthesis by this siRNA small molecule technology. And that's being done right now, and I'll show you an example. And that way, you don't even make the PCSK9, let alone blocking it later on. So these are the two methods to achieve our goal. Now, speaking of the monoclonal antibody, as I mentioned, we have that available, two drugs, and both of them have gone through this major cardiovascular trial. Look at the number of people in the 48 trial with avulacumab, 27,000 people, and another 19,000 in Odyssey trial with alirocumab. And you can see huge reductions. These people had very high cardiovascular disease to begin with. They were either with CV events or had very, very high risk, and most were on high or moderate intensive statin dose, whatever they could tolerate. And you can see the baseline LDL was close to 80, and within weeks, it brought down to 30. So this is how important this reduction is. 60% reduction on top of statin, 30. And same thing happened with alirocumab, starting a little bit higher, but again, 60% reduction going down to about 40 from about 118 or so. So these kinds of numbers were never seen before. First time that we could see lowering of LDL cholesterol to that level. With that approach, this is what happened. Both of these studies were published earlier, as you know, a few years ago. And the avulokumab trial showed over the course of about 2.5 years, about 15% reduction in major MACE events, and actually 20% reduction in the 3-point MACE event, not shown here. Exactly the same thing happened. It's amazing how exactly the same 0.85, and same 20% reduction. Unfortunately, these trials were stopped early, which may have been a mistake, but they didn't want to take any chances. You can see the curves are still diverging. So the actual reduction could have been higher had these studies gone longer. But the point is that both showed a highly significant reduction in LDL cholesterol and reduction in the events. Okay, what about key adverse events with these drugs? One question right away that comes up is, can you lower LDL cholesterol to 30 and even lower and not get any side effects in your brain, any neurocognitive function, for example? This was looked at extensively in this, particularly the avulokumab trial. So here is, first of all, muscle-related events, which sometimes limit the use of statin. You can see there was no difference between the placebo group and avulokumab. So these drugs don't cause myalgia. Secondly, they don't cause diabetes, as far as we know. Just a slight increase here, but not significant, 8.1 versus 7.7. We still need to follow people to make this point very, very definitively, but so far doesn't appear to have any diabetogenic effect, unlike statins. And finally, a huge battery of tests was carried out in this avulokumab trial. You can see by all those tests, there was absolutely no difference in neurocognitive function. Again, I think this phenomena has to be studied over a longer period of time because these are relatively short term for that purpose, and mostly looking at various ages, not very old people. Okay, one side kind of view here, there was an earlier studies, in this case with avulokumab, again, showing that not only they reduce LDL cholesterol, but they actually reduce atheroma volume. So basically they cause regression of atherosclerotic plaque, seldom seen with other drugs. High intensity statin might do a little bit, but this is much more so. 64% versus 37% of the people achieve some degree of reduction in the atheroma volume. So very exciting data, very much in practice right now. We've been using it from the time these drugs became available. Of course, the main issue is getting the insurance companies to pay for it. And I know that in countries like India, still very expensive, but as time goes on, hopefully this advantage of these drugs in causing further reduction in events will be taken care of by lowering the cost. One sidelight, once again, I want to show you because we published this from a meta-analysis about 2 or 3 years ago, effect of these agents on LP(a). We don't often talk about LP(a), but it's an important genetic component. And you can see that in this 9 different randomized controlled trials with diabetes and pre-existing cardiovascular disease, almost 1,000 people, we saw a 30% reduction in LP(a) level. Same thing happens with the other PCSK9 inhibitor, avulokumab. And of course, whether you look at just alirocumab 150 or 75 going to 150 without statins, these are totally statin intolerant, still 36%, same reduction. I should have mentioned that these drugs, there are monoclonal antibodies, they're given every 2 weeks, sometimes every 4 weeks, but most of the time every 2 weeks by simple disposable pen, which we use. Okay, now the last approach in this PCSK9, very exciting again, is this novel siRNA approach that I mentioned, which actually blocks the synthesis of PCSK9. What is the advantage of that? The advantage is you're not making PCSK9 synthesis due to this, this small molecule technology. There are several studies that have been carried out. I'll show you only one of them. 1,500 people. This is an efficacy study, mean age 66, LDL was 105 on maximal tolerated statin, and they gave them inclisiran. Now, the advantage of this drug is it's very long-acting drug. You start it, use it in the beginning, 2 injections over 3 months, 0 and 90 minutes. Then you give it every 6 months. And this was done in this efficacy study. You can see, just like the monoclonal antibody approach, this is one of the many studies that have shown the same result. This is Orion 10. You can see about 55% or so reduction on top of maximal statin dose, similar to what we saw with the monoclonal antibody. And actually, just to show you here, the percent change in the PCSK9 level. PCSK9 itself went down by 80% or so. Now, having said that, I should mention that the long-term cardiovascular trial with this agent still in progress. Okay, this will probably be completed sometime by the end of next year. But while we're waiting for that, just 2 days ago in England, this drug was approved. And big stories, I just couldn't help making a slide. Revolutionary jab to stop heart attacks, or miracle jab to stop heart attacks in these major newspapers in England. FDA is still looking at it. They have been looking at it for a while, and hopefully they will approve it. But National Health Scheme in UK already has, and they project how many people already are at risk after high-dose statin. So they're expecting a lot of people further as the cost goes down. Okay, so in the remaining time, I'm going to talk about beyond PCSK9. What are the novel and emerging options for further reducing LDL if, for example, you cannot use PCSK9? Is there a simpler approach like a pill rather than an injection every 2 weeks or even every 6 months? Some people just will shy away from any injection no matter what. Of course, the inclisiran injection actually is not a single injection. It's a 30-minute infusion. So the staff has to be trained to use that. So first drug I'm going to say a few words about. In fact, the only drug I can go into detail is bempedoic acid because it's now available on the market. It's an oral ATP citrate lyase inhibitor, currently approved only for people with pre-existing cardiovascular disease because their cardiovascular trial is also still in progress. So approved for secondary prevention or patients with FH who have very, very high LDL cholesterol, which we know cannot be controlled with statin alone. PCSK9 is an option, or bempedoic acid now is a second option. I'm still having problem getting it approved in people with severe statin intolerance. Hopefully that will change. Then there is this drug I'm not going to talk about, very exciting drug. It's an angiopoietin-like 3 inhibitor. Very interesting physiology, a topic for another time. And they just published several papers, one in New England Journal, one in Circulation. It's called evinacumab. It's available on the market, but only currently approved for people with refractory FH patients. So hopefully you will not see many of these patients, but it was just approved a few months ago. So we have one more option. And there are some thyromimetics. It's an old story that are still being developed. And the old thyromimetics were actually discontinued because they had a lot of thyroid-like, thyroxine-like effects as side effects because they were not selective against the THR receptors, thyroid hormone receptor. But this particular progress now is taking place with the thyroid hormone beta receptor, which is more specific for cholesterol reduction. And who knows, someday we might be talking about a CRISPR technology to totally extinguish not only the cholesterol issue, but the potential loci for atherogenesis. There are so many different steps through which cytokines and various other loci that one can talk about that lead to atherosclerosis, a topic for another time. So bempedoic acid, how does it work? Let's go back to our cholesterol synthesis that I showed you in my first slide. Okay, so this is again cholesterol synthesis going all the way down from citrate, HMG CoA reductase working here with statin. And all you have to know is that bempedoic acid actually works 2 steps proximal, okay, upstream from the HMG CoA reductase site. So this blocks the synthesis of cholesterol right here before it becomes acetyl CoA from citrate. For some strange reason, this does not actually result in some of the side effects that we see with statins. But it's a very interesting technology. In fact, there are mutants again, like the PCSK9 mutants that have been described in ACLY, which actually are associated with less cardiovascular disease. So very interesting indeed. So by lowering LDL, by lowering cholesterol, they also turn on LDL receptor synthesis and thereby leading to LDL cholesterol reduction. Now, again, there are many trials. These are all efficacy trials at this point, and I'll show you just 4 trials recently published together, again shown here. In 2 of these trials, people had persistent hypercholesterolemia despite maximally tolerated statin therapy, 1 pill a day, and you can see the LDL went down 16-17% beyond statin-induced reduction. Same thing with the second trial. Okay, and then there on the right, you can see there are 2 trials in people who are totally intolerant to statin. It's hard to find these people who are totally intolerant, but they found 600 people in these multi-site studies. And you can see they did even actually a little bit better, maybe because the baseline LDL cholesterol was higher to begin with, 130 versus 104 here. So they went down by 24% in each case. So that's very interesting. So right away, you might ask the question, how about a simple pill like bempedoic acid? Why not combine it with ezetimibe, which works at a different site, right? That's a cholesterol absorption inhibitor. And that's exactly what was done. Few side effects, very few, we have to be vigilant of, particularly slight increase in uric acid, and their cardiovascular trial is likely to be finished next year also, 2022. So watch out for it. But again, even though the randomized control trial for cardiovascular risk reduction is still in progress, the FDA approved both this drug as well as combination with ezetimibe in the same pill. Nexletol, the first drug, and Nexlizet, commercially known as. So this is a study when they added bempedoic acid to ezetimibe versus placebo. Okay, so people either got ezetimibe on top of bempedoic acid or they got placebo. And very interesting, already these people were on bempedoic acid, and adding ezetimibe made another 24% reduction in LDL cholesterol, another 30% reduction in HRCRP. So the efficacy is great. It's really nice, but we need longer term data. We still use it in occasional patients when PCSK9 inhibitor is not affordable. And I have several patients now that are using the combination as well, in some cases just bempedoic acid. Okay, so this is now the last question you might ask. Well, what about adding bempedoic acid to PCSK9 inhibitor? Why not? There are not many patients showing the efficacy of PCSK9 that I talked about, but there'll be people with FH, or very high LDL cholesterol, who still cannot be in the target range with the PCSK9 inhibitor alone. So why not we look at this combination, which has actually been done. Phase 2 study so far, baseline LDL was 103 on top of avulokimab. And then they got this drug. You can see it just appeared online, and there was a 28% reduction. Amazing. 28% reduction on top of PCSK9 inhibitor, whereas those on placebo, of course, did not change. So overall, a 30% reduction. So, I mean, there's no debate over the fact that we can achieve very low LDL cholesterol, get it down to 50 if we have to, and get it down well below 70 in many cases. Very few side effects. PCSK9 inhibitors are amazingly well tolerated, just local site injections, and bempedoic acid, as I mentioned, we have slight increase in liver enzymes and some increase in uric acid as the main side effect. You have to watch out for that, particularly in people with gout or very high uric acid level. So I will end on this last summary slide that actually was also published now last year, where I guess talked about overall options for ASCVD risk reduction in statin-treated patients. What do you do on top of statin, people who are still at very high risk? So here they are. Once you get to that point, what can you add? I already mentioned these three: ezetimibe, PCSK9 inhibitors, antibodies, and inclisiran, as shown here. I did not talk about icosapent ethyl, which is a separate story in people with hypertriglyceridemia, REDUCE-IT trial, which I was fortunate to be a co-investigator. And so if you have a patient, don't forget that on top of all this, you still can use icosapent ethyl if they have baseline triglyceride, as shown here, and they have diabetes and 2 other risk factors, or diabetes age 55 and 1 other risk factor. That is the current approval by the FDA. And finally, bempedoic acid trial, just like the PCSK9 trial, is currently in progress. So by next year or year after that, when we can meet in person on site, hopefully you will invite me to bring you up to date on that particular update with both of these ongoing trials. Thank you very much.